Okay. Oh, hang on, let me get out of this. There we go. All right, back.
Is there anything you guys, May, Scoobler, don't need clarifying?
No, for me, it's just kind of continuing to see examples and going over it. I think the repetition helps me.
I
And
agree.
then just kind of realizing, I mean, I think two examples instead of seeing like respiratory alkalosis, respiratory acidosis, like actually having like a example with each, whether it's DKA or asthma or whatever. I think seeing that too helps me kind of picture it better instead of just seeing these terms, seeing what we would actually be dealing with.
Yeah.
Gotcha.
As that way, like when you see metabolic, you can think, okay, it's going to be something with diabetes or whatever. I think that kind of helps me out too.
Yeah, so there'll be different things. Like they may give you a scenario where you have a diabetic patient, blah blah blah. You know that, and they may say, whatever. You know it's a diabetic, and they may say you arrive at the hospital, and the doctor tells you the patient has a pH of 6.8. Is this patient what? So obviously, uh, diabetic, I painted a picture of a metabolic acidotic patient. They're just testing your knowledge to see if you know what the pH scale is. They can do it that way. They could paint the picture of the diabetic patient, making sure you understand the difference between metabolic acidosis and respiratory acidosis. Um, most of the time, scenario wise, the respiratory alkalosis is going to be, an anxiety attack with hyperventilation. And the metabolic alkalosis is probably going to be an overdose of some type. Um, but they don't paint too many pictures of that. The only way to distinguish it in an overdose between metabolic acidosis, metabolic alkalosis, they would have to, I don't know, they would have to give you a lot of signs like, even if they give you slow respiratory rate, well, you don't know that that's not from the drug, causing respiratory depression. So, you guys feel pretty good about the buffer system?
Mm-hmm.
Mm-hmm.
And y'all understand like the chemical breathing from the brain stem. Pons here, that's the respiratory center. It's going to have your chemoreceptors.
Mm-hmm.
Those chemoreceptors are
central.
Those chemoreceptors are in the aorta.
Yeah, those central chemoreceptors are here, and if you're looking, here's your aorta, and the peripheral chemoreceptors are right here in the arch of the aorta. And so when they notice that increase or decrease in CO2, they report here. These guys up here monitor acid and CO2 as well. And so these guys can send a message back. Okay. And they may send that through the phrenic nerve. To increase the contractions, right? So that we can, increase the respirations. So we want deep contractions, fast contractions to increase the respiratory rate to blow off CO2. Or if it's the patient's alkalotic, decrease respiratory rate. But all of that happens between the receptors. So yeah, and so I feel like y'all are pretty good with this.
Mm-hmm.
I always want to put water first. I don't know why. Yeah, let me put that a little straighter.
The way you write that last one, the renal component, it's flipped in the book, and there's a negative sign like right above the 3.
Yeah.
So it's HCO3 negative plus H plus.
Yeah. Yeah. I just write it different. It's the same though.
What is that little negative sign doing above?
It just means that oxygen is a negatively charged.
Okay.
That's all it means. Oh, I don't need to. Hey, you know. But anyway, yeah. Because that goes back to, so you have these negative charges and your positive charges. And when you're talking about the cell, like we were talking about earlier, the cell always wants to be even on the outside and inside. So that's why I have potassium here, sodium here, calcium kind of in and out, hold the door open. So when I have a bunch of hydrogen show up, it'll start letting hydrogen come in. And so that it has, an equal charge, it'll start kicking out this potassium. And it'll start kicking out calcium. And hydrogen will start setting up shop in here. And so that's kind of how that works.
And when someone becomes hyperkalemic or the hypersemic, whether it's they're meaning it's going into the bloodstream, right?
That's right. So when we do when you get blood drawn at the hospital, wherever you're at, doctor's office or whatever, what we're reading is extracellular results.
Okay. All
right.
that fluid outside the cell.
Right. And this is inside the cell.
Right.
So the results we're getting is extracellular. And so if we notice that you're hyperkalemic, okay, or hyper K or hyperkalemia, then we know that potassium and calcium are being forced outside the cell. And that's a problem. And so, because these guys control muscle contraction and sodium potassium pump. And so that could be, we could have cardiac, irregular cardiac rhythms leading to cardiac arrest, especially with potassium. The body's very sensitive to potassium.
Sensitive to too much?
Either too much or not enough.
Mm.
And it does not like that potassium to be off at all. And so when it starts getting either hyperkalemic or hypokalemic, you start having irregular cardiac rhythms. And that's why you got to fix it pretty quick. Look over my notes, see if anything left this morning here. I forgot to mention too that let's see here. When I was talking about this morning, that bones, right? The actual skeletal system can absorb excess acid and bases. And it can it does that, but it can also release calcium. So the skeletal system does play some minor role in acid base. But the three main ones are always going to be respiratory, the bicarbonate buffer, and renal. The bone, bones do have some play in it, not a lot.
So the circulating bicarbonate buffer system is just how it is in the blood before your body decides whether to breathe it out or to use the renal component, right? It's the first line that tries to balance out the scales, so to speak, before whether it needs to either breathe it out or, I guess, which is the faster option and faster than renal anyway. I'm having a hard time visualizing what it even going on there.
That's okay. So let's see here. I'm having a brain fart here. Duh. Sorry, kind of tied it. Oh, there we go. Daggone it, man. Okay, so you're right. This is always your first line of defense. And because this is always changing after you eat, after you drink, all is always going on. This is either carbonic acid or it's bicarb. One of the two all the time. And so what it does, it's always swapping back and forth. So this is working all the time. When you start becoming acidotic, then it's going to call upon the respiratory part to come into play, because this can start within just a minute or two. Just long enough for the for the pons, where the respiratory center of the brain is, to send that message to the diaphragm. Hey, let's go. Right. So this would be second. And this is your renal section over here. And this would be last, because usually days or a day before it kicks in. So you're right. So just know that this is either losing a hydrogen or accepting a hydrogen all the time. Anything else?
I think I'm good.
You look like you're so stunned. Y'all are like, oh my God.
Yeah, that's exactly how we feel.
Is it really? You feel like you just...
It's making sense. It's just a whole lot.
Yeah. Just always take it back to remember the blood. What's going on with the big picture, you know? What's going on with the big picture? Your alveoli. You know, and so this is going on all the time down here, right? You got your blood cells. Right, and they're constantly letting out O2, exchanging that for CO2. And so that's where the first part of this kind of comes in. We see chemical stuff here, CO2, O2. And so we know that when we're thinking about blood, we got to think about water, because blood's mostly water. So we know that CO2 plus H2O, there we go. Well, that gets us started. And we know that these guys over here get rid of CO2 because that's what they're receiving, and they're giving O2. And we know at the end of the day, if we don't get rid of CO2, we're going to have a lot of acid. So just think of it like that. It kind of gets you started. It gets you started about what's going on. And then what you think about is, okay, well, who's in charge of this? Well, the brain is. You got your brain over here. How does it know? Well, it's got receptors, right? Receptors there and receptors in the brain. And between these two guys, they decide on what the levels are going to be. And so just think about that. Think about what is happening. And so then you can just add your medical condition to it. So, asthma. Okay, well, that's a respiratory problem normally. So what's all going to happen? Well, if I'm retaining hydrogen, I'm going to have to increase that respiratory rate. I'm going to need to get a buffer to reduce acid. That's bicarb. And just kind of work your way through it like that.
That bicarb, that's separating from one hydrogen ion to get HCO3.
That's it.
To make it more or less alkaline.
Right. So we're going to lose a hydrogen if we're acidic. We're acidic. That's what's so cool about a weak acid. It cannot hold that hydrogen easily. So it gives it up quickly. And if it gives it up quickly, it turns from something like an acid to a base.
Okay. That makes sense.
So that's what's so pretty. That's all you're doing. To get HCO3, you're just getting rid of a hydrogen.
Right. Whereas on the other end of the left, you're separating it into water and carbon dioxide to easily breathe it out more.
That's right. So that's exactly what's happening. The blood's already kind of doing that. It's mixing with water in the blood, right? And so that's the buffer system. And then that other 23% is going out. It uses most of the CO2 for a buffer. And then the between the brain with the central chemoreceptors and then the peripheral chemoreceptors, they pick up on, am I acidic or not? And if I'm acidic, the brain's going to say, hey, we're acidic. Let's get this buffer going. Let's drop a hydrogen. Let's get some bicarb going. And let's increase respiratory rate to get rid of as much CO2 as we can out. Let's breathe it off.
So those two processes to the left and the right can be happening simultaneously.
They do. They do happen simultaneously.
That makes sense.
Absolutely. This guy in the middle kind of happens all the time. Like I said, he's pretty much all the time. But let's say you start having trouble breathing, then this guy really gets on the horse to start dropping hydrogen, producing bicarb, and what the chemoreceptors and the brain work to increase that respiratory rate to get rid of that CO2. And so you go to the hospital, they do something called a blood gas. They check your blood gases. And what they're doing is they're drawing some blood out of an artery, not a vein, because we want to see, after it leaves the left ventricle, we want to see what the oxygen saturation is. So we want an artery, not a vein. Veins down here end up bringing blood back to the right atrium. We want an artery because it's leaving. Right. It just got oxygenated and it's coming out. So what we'll get is an arterial blood gas, and we'll see like what the partial pressure of CO2 is. But we'll also, what's kind of cool is we can actually measure the bicarb. And so if we see a high CO2 rate, like 50, and we notice the bicarb's high too, whatever the level is, I can't remember now, then we know without a doubt the body's producing bicarb, HCO3, because it's acidotic, and this PaCO2 is high, so this patient's in respiratory acidosis. Now we can get a partial pressure of O2 as well in that test. And we already know it's the same, 94 to 100 is normal. So if we get a PaO2 of 70 and we get, a high CO2, we know this patient's suffering. Let it sink in. Soak it in. Just soak it in. That's all you can do. We're not done with this. We're going to be doing this tomorrow.
You said tomorrow?
Yep.
Any further down, like how the nervous system controls things like that? Or just going to hit this again tomorrow?
Probably just hit it again tomorrow.
Okay.
I've noticed it usually takes a day or two for everybody to start getting it.
In terms of in this chapter, are you going to like point out like the extra bones or the extra nerves we're looking out for now? Like if I turn to like the certain section, there'll be slightly more anatomy than was in our previous book. Are you going to point out more specific ones we're looking for now?
I'm probably going to, I know one thing I'm going to hit a lot is respiratory acidosis and metabolic acidosis. I'm not worried about because I know this is a lot on registry. So I want to make sure everybody gets this. So the test will include a lot of this. But that's about as far as I really know right now. I need to review the exam a little bit and kind of get a feel for it, but I'll let you know. We got plenty of time.
I'm good. If anyone else has any questions.
No, I think I'm good too.
All good.
Good. All right. I will see you guys tomorrow morning then. And I appreciate y'all coming. And I'll post this video on YouTube on the channel as well. So in case you guys need it or anything. But y'all have a good day, man. Just don't worry about this. We'll have this. We'll get it down.
You too.
All right, guys. Take care. Bye, y'all.